Hello, everybody. The following session is about improving efficacy and efficiency in your clinic. It is my honor and pleasure to introduce the first speaker, Professor William Ledger. Professor Ledger is the head of discipline of obstetric and gynecology of the Faculty of Medicine at the University of New South Wales, Director of Reproductive Medicine and Senior Staff Specialist at the Royal Hospital of Women, and a fertility specialist at City Fertility in Sydney, Australia. William is a member of the editorial board of 9 scientific journals, author of more than 270 journals articles and 17 books, and president of the 13th Congress of the Pacific Society for Reproductive Medicine. His research interests focus on in vitro fertilization and assisted reproduction, impacts of reproductive aging and disorders such as endometriosis, premature ovarian failure, and polycystic ovary syndrome on fertility and quality of life, reproductive effects of cancer treatment, and on fertility and health economic and demographic aspects of infertility. His presentation today is optimizing of oocyte collection, efficacy, and safety. So William, please go ahead, the stage is yours.
Thank you for that kind introduction. It's very pleasing to be able to speak with you today, because the second most important thing in IVF is giving the woman, giving the couple a healthy child. The first most important is to avoid any damage to the health of the person who's going through the IVF cycle. And that really is the topic of efficacy and safety. The efficacy of an egg collection is about the process of putting eggs in the lab. The safety is about avoiding harm to the woman who's having the egg collection. And I'd argue perhaps that we should have put the title the other way around. I think we should put safety before efficacy every time. So what do we mean by those two words? Well, you might argue that efficacy is to maximize the number of oocytes collected, make sure that from the follicles that are available, we have a high yield of eggs, obviously avoiding damage to the zona or to the oocyte that lies within it, and being fairly quick and efficient with minimization of cost, but also perhaps very importantly, maximizing the patient experience. So if she has to do an egg collection more than once, this is not a procedure that she will be dreading and finding very challenging. I think a few topics for safety. Firstly, more and more, I think globally, but certainly in UK and Australia that I know, we're trying to avoid general anesthesia for the majority of cases. However, it's really important to avoid procedural complications, as in any surgery. And in egg collection, I guess hemorrhage is probably the most acute and worrisome problem we face. Looking at equipment, we need to be able to visualize the egg collection needle under ultrasound at all times. And again, for safety as well as efficacy, complete the procedure in a minimum time compatible with good practice. I mentioned general anesthesia, and the British National Institute for Health and Care Excellence, NICE, brought these guidelines out many years ago now, 2004, but they've been updated and they survived the update, that conscious sedation is a safe and acceptable method of providing analgesia. And there are guidelines about safe practice of administering drugs. And I think those of us who do a lot of egg collections know that there are probably a minority of women who would do better with a general anesthetic, but the majority can manage well with conscious sedation. There are many things that influence the amount of pain that someone experiences during an egg collection, and part of it is her own ability to manage pain and to be positive about the process and not arrive in the egg collection theatre full of terror and anxiety with a very high adrenaline. That's going to be a challenge from the start. However, the environment, the people around her, the place in which she is should feel safe, should feel friendly, should not be full of too much threatening equipment that can frighten people. For our conscious sedation egg collections, we encourage the partner or a support person to be with her during the process, and that seems to work well. We might think about some preoperative preparation, maybe taking some analgesia or some sedation before the procedure. Not something we do frequently, but we can if need be. And then it comes down to equipment, having the best possible equipment, a good ultrasound scanner so you can see the pictures well, and being well trained. And we run a big training program here at Royal Hospital for Women, and we supervise our more junior colleagues learning how to do egg collections under close tuition, and they become skilled quite quickly. Then we can think about what we might use during the egg collection. We might think about the pelvic anatomy, which can also vary, and people's tolerance of pain falls as the procedure goes on too long. We've all seen this during labor, that as a woman labors for many hours, her ability to tolerate pain is reduced, and that's the same during an egg collection that takes too long. We do have complex cases. It's been mentioned in the introduction, my interest in oncofertility, and this means doing egg collections on teenagers and young adults, and they often do better with a general anesthetic. I think transvaginal scanning is not something that many teenagers find acceptable under any circumstance, and if it's prolonged and involving pain, it's maybe better to anesthetize this group. And similarly, egg donors who are not doing the procedure for their own child but to help someone else might be more willing to proceed if they have the option of a general anesthetic. Some people find the whole process very frightening. Some people have had a previous bad experience with an egg collection elsewhere. And as we all know, some of the pelvic pathologies increase the risk of pain, significant endometriosis, significant pelvic adhesions, sometimes a hydrosalpinx, which is difficult to operate around and you don't really want to go through, might need to be thought about more carefully. And then someone who's had previous pelvic inflammatory disease with sepsis, the pelvis might be quite frozen, use of a needle might be more painful than on average, and again, it might be necessary to think about more than conscious sedation for those people. And then the specific medical problems, again, the oncofertility community, some of them are profoundly thrombocytopenic. We've done egg pickups on women with platelet counts of around about 20, with platelets running, with clotting factors, with advice from consultant hematologists, and a general anesthetic for them is probably better. You don't want to have a pelvic collection of blood which forms a hematoma, because then later, if they're having chemotherapy and are neutropenic, there's a risk of infection which can be quite profound and difficult to manage. Those women who have a pre-existing coagulopathy are going to bleed more and need better management. Those that have a very high follicle number obviously can struggle. It's going to take a long time, and you're going to be deeper in the pelvis collecting those follicles or aspirating those follicles at the top of the ovary. But also, perhaps paradoxically, women who only have 2 or 3 eggs, the ovary might be more difficult to access, it might take longer, and again, it might be more painful. And again, these pathologies, and I put cases that have had ovarian transposition before radiotherapy. We've seen a few of those in the last 2 or 3 years where we do a transabdominal egg collection, which again is probably better done with a general anesthetic. And women who are very obese, because it's harder to find the ovary and access it, and not necessary maybe for a general anesthetic, but be prepared for a more challenging procedure, maybe with a more senior person doing the egg collection. And one of the things that the world of IVF remains very enjoyable to be part of is it keeps changing and things keep improving. We've seen many, many improvements in the embryology lab. We've seen many improvements in the way that we stimulate ovarian follicle growth and development, but we've also seen technological improvement in the way that we do egg collection and embryo transfer. And one of the things that we've needed for a long time is a needle which is thinner than the traditional 16 gauge needle that we've had since the 1990s. But until recently, the problem's been that the thinner needles are too flexible and difficult to use. And so we want stiffness as well as thinness in the ideal needle for egg collection. And this, I think, has now been achieved with the Sense needle from Vitrolife. And you can see that the reasons I'm saying that. The picture at the top shows you that the final 50 millimeters of the Sense needle, the bore, drops from 1.4 millimeters 16 gauge down to 0.9 millimeter. And you can see on the little diagram in cross section here on the right, that means that there is 59% less cross-sectional volume for the Sense tip compared with the conventional tip. But the stiffness is maintained because apart from the lower 50 millimeters, the rest of the needle is standard gauge and therefore is not too floppy, not too difficult to use. And you see it magnified here. There is a shoulder at 50 millimeters, and it's rare, it does happen, it's rare that we need to penetrate into the ovary more than 5 centimeters. If you do, you'll feel the resistance as the shoulder enters the tissue. It's not a problem. You just know that you are quite deep in the ovary at that point. The other advantage of the Sense needle is that it has very efficient echo markings on the tip. And as you can see from the picture, you can either see the elongation of the echo markings along the tip, or the tip itself might appear as a bright dot. And I find this particularly helpful when I'm teaching a junior colleague, because we can observe the tip of the needle at all times, so I know that they're in the right place within the ovary and not drifting out of the ovary, possibly into the vessels or the bowels. So the echo marking is an advantage of this needle. And I thought it might be helpful just to run a brief video to show you how this works in practice. And I'm just going to talk you through this. So in the public hospital, we do our egg collection in the main operating theatre. So this is me scrubbing before we go to do the egg collection. And you see I have my embryologist there. You saw Sarah briefly, you'll see her later on. We carry out the procedure under sterile conditions. So we still cleanse the vagina with chlorhexidine and then saline to wash away the chlorhexidine. My assistant there is showing you this is a double lumen case, just for interest. And we can take the needle from the sterile wrapper, and the surgical scrub nurse will set up the aspiration tubing there, link it to the needle, and you can see the bung that's going to go into the aspiration tubes. We have the sterile condom that covers the needle, and I'll put that on. It has ultrasound translucent gel in the tip, and then the needle guide just nicely clips onto the scanner, and just give it a wobble to make sure that it's fitted on properly. Do a preliminary assessment just to see where the uterus and the ovaries are, identify the pelvic vessels and any other landmarks, and then you can see how easy it is to visualize the needle as it goes into the follicle. You can see the tip and then the laser etched markings there. And we're just draining follicular fluid. And as you see, you just go from one follicle to the next. Trying to keep the tip of the needle guide in the lateral vaginal fornix. As I mentioned, we have the aspiration pump on 135 millimeters mercury, and having the embryologist adjacent to me is a major advantage, because I can get feedback straight away, whether we are getting eggs or not, and something about if the follicle doesn't have an egg, whether there are granulosa cells, are we actually aspirating a cyst? Is much more helpful than having to aspirate all the follicles and only getting the information later when the embryologist has inspected them. And we just keep going until all of the visible follicles are aspirated. I have a look of intense concentration on my face. I have never seen myself doing this before we made this video. I'm obviously trying very hard to make sure it works. And so you can see in practice, the Sense needle follows the line of the dots on the scanner pretty much like any other. So then, just to take you through this randomized trial that was published this year in fertility sterility from Nijmegen in the Netherlands, and some very eminent people are named on this paper. And it was a randomized comparison between the reduced gauge Sense needle and the conventional 16 gauge needle. And they used IV fentanyl for sedation at the patient request. And you see here the comparison between the two. They had 47 patients who had the Sense needle and 48 who had the standard needle. They were similar in their BMI, their parity, the number of follicles aspirated, but importantly, the number of eggs collected was very similar. The duration of the procedure was very similar, and the pregnancy rates were the same. However, when you look at pain scores, you can see these were either low, moderate, or severe, and then the visual analog score average is there also. You can see that the reduced bore needle had significantly more patients who described low or moderate pain, and significantly less who had severe pain. And that was mirrored by the amount of fentanyl that had to be given. The majority of patients had no fentanyl, but those who needed at least one shot of fentanyl, significantly higher in the standard needle group rather than the reduced needle group. So less pain recorded and less requirement for analgesia with the thinner needle, which is hardly surprising, but it's nice to see documented. But perhaps more importantly than pain even is this problem of bleeding that we all encounter from time to time when doing an egg collection, was significantly less in the reduced bore group than the standard group. and the bleeding more than normal, 9 patients in the standard compared with only 1 in the reduced group. And this group liked to use atropine for for bleeding control, not something personally I've needed to do, but they use atropine in 10% of the cases with the standard bore needle and only 2%, i.e. 1 patient in the group that had reduced bore. So less bleeding, less pain. The procedure took the same amount of time and had the same amount of eggs and pregnancies. So I think fairly good evidence that this needle is maybe to be preferred for most, if not all, cases that we do. My own group back in Sheffield produced this poster at ESHRE. I show it because this is nurse-led egg collection. Most egg collections around the world, I think, still done by doctors, but nurse-led egg collection with mild sedation. When nurses are doing egg collection, they don't have the doctor's latitude in what drugs they can select. So this was very low amount of analgesia, less anxiety, shorter duration than the same number of eggs when they use the reduced bore needle compared with the standard bore. And then I'm asked just to report what I do. And I can say to you all that I was introduced to this needle 2 years ago by Dr. Graham Hughes here in Australia, who is one of the senior specialists in the world of IVF in this country. And he talked me through how to use it. He'd been using it for a while. And I think it's important that you develop the skill. It's slightly different using this needle from the conventional one. So I saw immediately the positives that were recorded in the randomized trial. There was less bleeding and less pain, but initially it took me longer to get the needle into all the follicles. I felt the needle was moving off the vertical line on the scanner more often, and I was having to come in and out through the vaginal vault more often with this needle because it's not so easy to move it laterally inside the ovary. But with only maybe 10 or 20 cases, you become proficient with a new skill. And I now feel confident that I'm quicker with this needle. It's easier for me. And the technique, now I have it, I'm skilled. I've done hundreds of egg collections with this needle. I've maintained the low bleeding, the low pain, but I'm as quick now with this needle as I ever was with a standard bore. It just takes a slightly different thought process to control it. This is the main difference, that on the left, you can see what you can do with a 16 gauge needle. You can swing it around inside the ovary and wander. Whereas with the reduced bore needle, it's important to accept that you may go in and out more often, but the trauma to the vaginal vault, the peritoneum, and the ovarian surface is so minor, it doesn't matter. So you might do 3 punctures instead of 1 or 2 in order to aspirate a big ovary. One that only has 6 or 8 or 10 follicles, usually 1 puncture per ovary is sufficient, but someone who has 15 or 20 per side, you might need to do more. And the other thing that I find helpful and has not traumatized our eggs and has not affected our pregnancy rate, we generally use the follicle aspiration pump at a suction pressure of 115 millimeters of mercury, and standard for the reduced bore needle, we run it at 135, and that means the whole process goes a little quicker. We use Penthrox, which is methoxyfluorine whistle. The patient controls it herself. She breathes on the whistle. It makes a little whistling noise, so we know that she's using it properly. And there's a hole at the top. She can cover the hole to get an extra dose if the pain is more severe. And usually they use about 1/3 of a whistle. They often fall asleep and they often chat to us while we're doing the egg collecting. And we would use that in our practice in about 7 out of 10 cases. The cases I described earlier, the very young patients, etc., we still have access with an anaesthetist to IV sedation, so the patient will sleep through the whole thing. I'm also asked about flushing, and when I was young many years ago, we used to flush follicles frequently, but over time it's become less and less practiced. And again, recently, randomized trials and meta-analyses have shown that it takes longer, but you don't, in meta-analysis and RCT, obtain more eggs or have a better live birth rate. And there's a nice quote from Bert Skokia in Fertility and Sterility this year: in both healthy and poor responder IVF patients, follicular flushing should be abandoned because it doesn't increase the live birth rate or the egg yield, and it prolongs the procedure time. And I would agree, for the majority of patients, that's correct. But it's nice in the world of IVF to have choices, and we have some patients who've been through this process many times, and the rules cease to apply. And my own approach to this is that I think we do have women who are only ever getting 1 or 2 eggs they don't fertilize well, they have poor embryo quality, and the pregnancy rates go lower and lower and lower. And we want them to stop. And therefore, I think it's important for them to know that we did everything we could. And so if I have someone who has only 1 or 2 or maybe 3 follicles and has had a poor egg yield previously, I'm quite happy to flush those follicles. If you only do that for the poor responder patients with a couple of follicles, it'll add at the most 2 minutes to the procedure. And we know there was nothing else in the textbook that we could have tried to maximize their egg yield. And we can honestly say that to them, that even though we did everything we could, we still couldn't get you many eggs, and therefore probably don't have many more treatments. And moving to ending treatment is one of the hardest things we have to do in the world of ART. And this is how we do follicle flushing. The Sense needle has a double lumen variant, and we would only do it, as I say, if there was a low follicle number, or for someone who's had empty follicle syndrome or quasi-empty follicle syndrome previously. We have done this for IVM, but currently we don't flush the IVM follicles. It doesn't seem to improve things, so we're doing IVM without flushing now. And we use the culture medium from the embryology lab, sterile GMOPS medium, and 2 or 3 flushes. There's never been a trial that tells you how many flushes to do, so we do 2 or 3 and hopefully we get an egg. You don't want to take very long. The culture medium is in the syringe with which you're flushing. It's getting cool, so don't do this taking 15, 20 minutes, just 1 or 2 minutes is enough. And obviously someone who's neutropenic and at increased risk of infection, don't flush, because you could be flushing bacteria from the vaginal vault through the follicle and spilling into the peritoneal cavity. So flushing is not for the cancer patients with neutropenia. So that's my presentation about efficacy and safety of egg collection. It is good to have new things. I'd encourage people to try and persevere. Don't give up after 1 case because it took a bit longer and it didn't seem quite as you'd expect. With practice, and it doesn't take long, for me, this has become the needle of choice, the procedure of choice. And I think for many others, the benefit of less bleeding and less pain might be the advantage that they will be grateful for. Thank you.
Thank you, William, for giving such an extensive review on egg collection. I have a few questions, short questions for you. Are you giving a routine antibiotic treatment while you do egg collection?
No, we used to, and we did for many years. And then we had a visiting specialist from another country who came to work with us. And she said to me, why are you giving antibiotics? It's expensive and there are allergic reactions. And for a routine case, you don't need to. So we've reduced our use of antibiotics to the cancer community. I think the oncofertility cases, it's probably wise, but 90% plus of our cases now we do not. And we've not seen pelvic abscess or increase in infection over the last 1.5 years that we haven't been giving antibiotics. And so I think the world is moving in that direction as well. Do you agree that it's become less of a practice than it used to be?
Well, I'm not sure. I know that we are giving, at the time of egg collection, routine antibiotics for our patients. Indeed, we didn't have a case of infection, but obviously it's a controversial issue. Another thing I want to ask you, are there any routine tests that you're doing while the patient's in the recovery room? Are you taking blood count as a routine before you release the patients home?
No, again, we've made things more streamlined. They stay with us for about 30 minutes if they've used the methoxyflurane whistle. We do routine observations and record them as if they'd had a general anesthetic, so the quality of nursing care is as good as it should be. But we don't do any blood tests. We don't measure hemoglobin or hematocrit unless there's been a problem. And we do take more care and have longer recovery time for the cancer fertility people who are unwell. We've had a few cases, for example, with a lymphoma with a mass in the chest, which makes the anesthetic more complex, and those people require special care. But for our routine fertility cases, no, we just observe them, and if they're well after 30 minutes, maybe with some Panadine, they go home.
In case of endometriosis, where you by mistake puncture the endometrioma,
Yes.
How do you continue? Do you aspirate? Do you flash? Do you give antibiotics? Do you stop the procedure? What are you doing?
Yes, it's a good question because it happens to all of us, however hard we try. And I think we all now try and work around the endometrioma, collect the eggs, but don't enter the endometriotic cysts. But it's not always possible. And sometimes you aspirate what you think is a follicle and it turns out to have chocolate fluid. I mean, this is an everyday problem. So we would try and aspirate the fluid. Sometimes it's so viscous, it's not easy to do. So if you start to aspirate the fluid, we'd continue. When the needle is dry, when there's nothing more to aspirate, you can see that the cyst has collapsed on the ultrasound. We then stop, change the whole of the set, change the needle, change the aspiration tubing, and then carry on with the procedure. And we would give them IV cefuroxime and metronidazole as a routine in those cases.
And the last question about the flashing and the double lumen needle. It's a very controversial issue, whether you have to flash or not. But I want to ask you, if you do the flashing, do you look at the different tubes? Do you separate what the flashing, and can you tell us if you get eggs in the second or third flashing session?
We're fortunate because we have the embryologist in the operating theatre or adjacent to us, so we can have instant feedback. So I would do an aspiration and ask whether we have an egg or not in the follicular fluid, and only if there's no egg do we do a flush, and then you can wait and flush and wait, so you know where the egg has come from. Was it in the aspirate or in the first flush or the second flush? And you're correct, sometimes we see the egg in the second flush. My question then is, was it really in the follicle until the second flush, or was it in the system the whole time and you've been flushing it in and out of the follicle? And nobody will ever know the answer, I don't think, to that question. But we do sometimes find an egg in a flush that would not, I believe, would not have appeared in the primary aspirate. And so in these low egg yield patients, it might be of benefit to them. But I do emphasize Burt-Skokia and the randomized trials have not shown benefit of flushing.
How many times do you flush the follicle until you said, well, this is enough?
I tell my students that I keep flushing till I get bored.
Okay.
Because there's no guidance, is there really? I think most of the eggs will appear within 2 or 3 flushes. If it's someone who has one follicle, often we do an IUI or just trigger, but if she really wants an egg collection for one follicle, and this might be her last ever IVF, you will flush that 6, 7, 8, 9 times maybe. But someone who has 3 eggs already and there's one more follicle, you might just give it a couple of flushes. I don't think there's any guidance from any of the big international societies about how often we should flush.
Right. William, I want to thank you for an excellent presentation. Thank you for being us today. And I'm sure that your presentation will serve a lot of our colleagues. And thank you again.
Thanks, Ed.